Hi there, I'm Colin Leslie, Editor-in-Chief of the Medical Post, and as we do every time we have a new issue of the Medical Post out on tablet, we record a little video to talk about what's in that issue. So I'm here with Tristan. Can you introduce yourself?
Yep, Tristan Bronca, the staff writer at the Medical Post.
So I think our first topic is the retailization of healthcare. So you wrote that cover story. Tell us what it's about a little bit.
Sure, so we basically looked at the phenomenon that is the rise of primary care clinics inside of grocery stores and superstores. So right now, I think the two biggest players in that are Primacy, which has about 140 locations, I believe, inside Loblaws, Loblaw stores, and the other big player would be Jack Nathan, and they have a partnership with Walmart, and I believe they have I'm going to screw these numbers. They have, I believe, 60, I want to say, but a lot less. But they're also newer. They opened up about 3 years after Loblaws, so they're about 10 years old now, and they're expanding.
Yeah. And so what's the relationship with physicians? Physicians are obviously signing up to work in these, and are they employees of these things, or how is it sort of
So
operate?
no, these clinics basically operate like most other clinics that aren't located in groceries and superstores, except being affiliated with the brand. Physicians also get a number of other perks. So a lot of these cases, they use their own EMRs, their own staff. They do everything sort of their own way. They're not employees, but they also have access to, for example, with Primacy, they have access to buying programs to get discounts on equipment and that sort of thing. And in both places, actually, they have access to like people that handle all the maintenance issues around the clinic and that sort of thing. So they don't really have to concern themselves with that as much. But other than that, it's basically like running a clinic on their own.
So I think that gives me a sense of what the upsides are from a physician perspective. What kind of concerns do physicians have about going into this kind of practice?
Sure. So I think probably the major concern would be that there's a very heavy emphasis on the walk-in model of care. Obviously, if you're located in a grocery store, the biggest bonus of being in a grocery store is that people who are just shopping can pop in to see the doctor. And while they may have a roster of clinics, it also lends itself, I guess, to a walk-in type model, and that obviously, in some people's eyes, threatens to undermine the move towards more comprehensive longitudinal care and that sort of thing. The other downside, one of the other clinics we looked at in this issue, beyond Primacy and Jack Nathan, is not a retail clinic per se, but they're called Apple Tree, and they actually they do a lot more in terms of the perks. So whereas Jack Nathan and Primacy sort of help them out with maintenance and that, Apple Tree not only does that, but they handle all of the administrative aspects for a physician. They have their own staff that's sort of centrally trained, and then they go out and they sort of work with different physicians. They help them with their EMRs if the physicians are maybe less familiar with EMR and that sort of thing. And people, some physicians see that as a downside because they're giving up some of their practice, or they're giving up their, I guess, freedom to run their own practice, but they also feel that it's a little bit more expensive to do things that way. So they feel that's a downside as well.
Obviously, these three have all grown quite rapidly in the last few years. What's your sort of expectation for the future around what's this? Do you think it's going to keep on getting bigger, or what do you think is going to happen?
Yeah, that's a good question. I think they're probably going to end up getting bigger, only because right now what I think we're seeing is patients are demanding a lot more from their providers, and I think traditional sort of group-based models of care are having a more difficult time delivering on that. We spoke to an unnamed source who said that I can't email with my doctor. We've said physicians or patients shouldn't be going to walk-in clinics because we need to be maintaining these relationships with our one and only primary care providers. And he says, well, I can't email with him, I can't get in to see him for weeks at a time. What kind of a relationship is that? And so I think as patients start to have more difficult times with access, we're going to see these clinics start to look a lot more attractive to them. So.
And I think also, and this is a bit anecdotal, but I think young doctors have a little less interest in running the mechanics of a practice. They just want to practice medicine. So
Yes.
well, great, interesting. Next topic is Canada's medical education system.
Yeah. So this was the topic of your editorial.
Yeah.
Can you tell us a little bit about what it's about?
Sure. So one of the nice things about being a journalist is you sort of get to go and to look at little different areas of the area you're covering so often. So I went to the Canadian Medical Education Conference in Montreal in April. Just sort of, I haven't been there before to sort of see what they were going, what they do there. And I want to get a sense of sort of how Canada is deciding how we get the right number and mix of doctors. And so basically they sort of ran down an example in Nova Scotia, which provides doctors for PEI, and New Brunswick. They sort of ran down that they try to have this model to predict how many radiologists we have going to need. And then in each province, it's up to the health minister to decide how many spots go to radiology, how big the medical school is. So they have a lot of autonomy, but we're doing that in a regional system. So that works. I mean, you get enough doctors, but doctors are obviously free to move to different provinces, and it's also when you're dealing with provincial numbers, it's much smaller. We're Canada, country of 35 million people, so it'd be better if we had national data. So they are starting to work on that. The Physician Resource Planning Task Force, along with its committee, the Committee on Health Workforce, is they've engaged the Conference Board of Canada as a service provider to try and get a model that will say at a needs level, national needs level model. And it's more complicated than it looks because, of course, every province is starting to use, or not every province, but many provinces are starting to use nurse practitioners and different kind of care providers, so the number of doctors you need is also affected by that. So that's sort of what they're working on these days.
And as you know, I was just in BC, and one of the stories that we're doing for the upcoming issue is about the recruitment crisis. And the sense that I'm getting is that there's a lot of work being done on the human resources front in each different province. I'm just wondering how you see the work being done in each different province sort of coming together or coalescing into like a national strategy. Do you think that's going to be accomplished here?
Yeah, I mean, what they're trying to do is they're trying to get this tool that will estimate needs, and then once they've all agreed on the tool and it's giving how much they think that the needs are going to be, then they hope that the health ministers will find it difficult to not go along with what this tool that they've all agreed to is today. Because right now, they obviously have their own autonomy to decide, but they're hoping that will start producing better numbers. Because obviously, if the numbers can be quite small. If for instance, Dalhousie in Nova Scotia is producing 6 radiologists per year. Well, if you've got if the university in Newfoundland is also producing slightly more than they need or something like that, you can get oversupplies quite easily. So the value of national numbers is big, and I think the momentum is there. It hasn't been in the past to get better national needs numbers and start using them. And it's a big frustration for medical school students because they have to make these choices about these specialties quite young, and the CARMS match, that's the number of spots that residency spots versus Canadian medical graduates is extremely tight, so that they don't get a lot of opportunity to change their direction if they made a wrong call in terms of a career.
And you see this sort of strategy that being good for young doctors being able to adjust, or do you not feel that it's going to address that as much?
I do. I think being a bit of a backstory, my grandfather was a family doctor in Alberta, and he practiced as a family doctor for a number of years, and then decided he wanted to try something different, and he retrained as a public health doctor, and eventually went on to be the Deputy Minister of Health in Alberta. Well, when you've got a tight system like we have now, doctors don't have an option for that, and I think we're losing something because of that. So.
Interesting.
Great. I think that's it. Thanks so much. Talk to you at the next issue.
Thanks.